This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology and training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology easily, one podcast at a time.
Hi, this is Jeff Ratliff, Deputy Editor of the Neurology Podcast, here with the Neurology Recall episode for February of 2025. In this episode of Neurology Recall, we're featuring a number of interviews we've hosted on the podcast surrounding a number of topics in neurology education. To kick us off, you'll hear the conversation I had with Dara Albert and Afsana Talai on the April 11th, 2024 podcast episode about a study they conducted to understand the gaps in understanding about psychogenic non-epileptic seizures among child neurology residents. In the next segment, you'll hear Jason Crowell speak with Sarah Louise Edwards and Zach London about game-based learning in neurology education. That conversation aired on the podcast on May 20th, 2024. On November 25th, 2024, Stacey Clardy had a podcast conversation with Casey Albin about the features and impact of educational social media posts in neurology. And finally, to conclude this episode of The Recall, you'll hear my conversation with Rachel Gottlieb-Smith and Catherine Zixies from the December 16, 2024 episode of the podcast, where we discuss the impact of artificial intelligence technology on the residency application and recruitment process. We hope this series of interviews will help listeners understand the breadth of work being done at multiple levels of neurology education. And listeners who are craving more can certainly turn to Neurology Education, the journal dedicated to topics in education within the neurology family of journals, to find more great publications on this topic. Thanks for listening to the Neurology Recall, and we'll see you next month.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with the Neurology Podcast and Thomas Jefferson University. Today I'm with Afsana Talai from UT Southwestern University in Texas and Dara Albert from Nationwide Children's Hospital in Ohio. Afsana and Dara are authors of a paper published in Neurology Education titled Educating Child Neurology Residents About Psychogenic Non-Epileptic Seizures. In this education research project, the authors sought to understand gaps in education on psychogenic non-epileptic seizures from both child neurology residents as well as child neurology residency program directors. Neurology Education is the latest spoke journal in the neurology family, and it can be found online at the Green Journal website and features articles across the realm of neurology education, including student education, resident and fellow education, or even topics in CME for practicing neurologists. And as more and more of us have all different types of learners rotating with us in our clinical spaces, the journal can really help you refine your teaching to both your peer providers in practice or those in training or even your patients. And so in featuring this article from Neurology Education, I wanted to talk with Dara and Afsana about both the current state of PNES education for residents in training, but also talk about some of the best practices that could be used, perhaps in educating both our trainees and our patients as we fill in these gaps. So Dara and Afsana, welcome to the podcast.
Thanks so much for having us.
Thank you for having us. Happy to be here.
So Afsana, I'm going to start with you, and I'm hoping you can give us a high-level overview of the study before we get into the details of what you did and what you discovered. How would you briefly summarize the findings of this paper?
Our group performed a needs assessment of current pediatric neurology resident trainees and the residency program directors. And we wanted to assess their perceived deficiencies in education on psychogenic non-epileptic seizures and understand what type of education is desired by these two groups so that hopefully in the future we can tailor a curriculum or a program for them so that we can improve education if we saw that that was needed. And so overall, our studies showed that while residents may report high levels of confidence in managing this condition, there's definitely a knowledge gap that they feel. And both residents and program directors want more standardized curriculum on this topic. Only about half the residents are even interested in caring for children with psychogenic non-epileptic seizures, which I think reflects, the uncertainty they feel around the diagnosis.
that contrast between confidence and knowledge and the fact that those two do not always correlate, I think is an important point to make. And hopefully we can dive into that a little bit more. And so turning to you, Dara, the project, as we just heard, sought to understand what are the education needs of child neurology residents when it comes to psychogenic non-epileptic seizures, or PNES. And in the introduction of the paper, you and the authors mentioned that there is some existing knowledge that distinguishing PNES from epileptic seizures is clinically challenging. Can you tell us, what did we already know about the state of clinical recognition and management for PNES, and how was this study going to sort of add to that knowledge or fill in some of those gaps or take it one step further?
We know that non-epileptic seizures certainly resemble epileptic seizures in a lot of ways. Somebody might have changes in their behavior, in their level of alertness, or shaking or jerking, movements that might resemble an epileptic seizure. And we know in clinical practice and also in the literature that these two entities can be confused. Sometimes people are recognizing these events, thinking that these events are epileptic seizures. And there is even data that suggests that patients are being treated as having epilepsy and given anti-seizure medication when indeed they don't have epilepsy, they have non-epileptic seizures. Now, a lot of that literature comes from adult data. We don't have a whole lot in the pediatric literature specifically, but given the similarities in terms of like clinical semiology for the events, I suspect that it's probably pretty similar in pediatrics. There was one really striking piece of data that I think illustrates this is in the ESET trials, the established status epilepticus treatment trial, where a group of researchers tried to see what is the best rescue medication to be given in the emergency room in patients in status epilepticus. I think upwards of 10 or maybe even 20% of the patients that they ended up treating for status epilepticus with medications turned out to have non-epileptic seizures. So that suggests that there's a lot of confusion out there in terms of how to recognize and differentiate these two entities clinically. And so we suspect that that would be true for trainees, especially who are still very junior in their clinical experience and knowledge, and child neurology residents still in training. We suspected that perhaps they would have some gaps in that knowledge or that ability to recognize or differentiate these types of events.
That's important. You make some very good points that, one, this is hard to do even in the context of, as you said, a trial targeting management of status epilepticus, presumably with inclusion criteria and experts sort of involved in that making this distinction is a challenge. And then building back again on what Afsaneh said, that while there may have been some lower levels of interest in treating this disorder, to treat epilepsy is to treat PNES, and the two are so hard to distinguish that can't have one without the other. So speaking of some of that confidence and some of that interest, Afsaneh, drilling down to some of the results, what did you all find with regards to the residents' current levels of confidence in their ability to recognize, to manage, to communicate to patients regarding PNES? And what are some of the needs for educators out there who may want to build a curriculum, or for societies in the field of epilepsy that want to build a curriculum? What are the educational needs that you identified in those realms that a curriculum might try to address?
We specifically asked about their confidence in communicating the diagnosis, since we know this is an area that previous studies have shown that neurologists struggle with, and even other healthcare professionals struggle with. 3/4 of our residents about reported confidence in their ability to communicate the diagnosis, which I realize may seem high, but we know that this is such a common condition and we want it to be much higher. It really should be a bread and butter diagnosis, just like you said, to have epilepsy is to have non-epileptic seizures in your differential. And then further, we know that the knowledge base is lacking because the residents, about 2/3, less than that, reported feeling knowledgeable in this condition, and only half felt their current education was sufficient on this topic. And so that really shows that there is a gap there that someone needs to fill with more education. Add to that all of our program directors reported a desire for a standardized curriculum on this topic. And based on the responses we received from both residents and program directors, what we really heard was that they really wanted a simulation-based education curriculum. And that makes sense because a lot of the diagnosis is communicating the diagnosis to the patients and families. And that's something that really needs to be practiced and observed for you to really learn it. And actually, Dara's group has even reported on their curriculum, and they've had really great success with it at their institution.
The skills that we're trying to teach here of talking to patients, talking to families, communicating the diagnosis does require, as you said, reiteration and practice, and simulating that certainly sounds like an appropriate way to go about that. Dara, I want to think about our listeners who are primarily clinical neurologists and are seeing patients with PNES, perhaps both children and adults or one versus the other. And you mentioned that a lot of our literature in this area does come from the adult side, and we might be making some extrapolations to the child neurology side. Do you think that the gaps identified in the child neurology trainees that Afsaneh just walked us through could be similar in practicing neurology clinicians out there?
I think potentially yes. And I have certainly experienced throughout my career and during my own training different approaches to making this diagnosis and communicating this diagnosis amongst my colleagues and professors, some of which perhaps were helpful and some of which were less helpful. I think it's really striking. One of the most striking findings from this study is that only, I think, 50% of our residents report actually wanting to care for these patients. I don't think this point can be underscored enough, that this is a very common presentation, and this should be bread and butter and just part of what neurologists see and do. And we need to have a level of comfort, but also compassion for these patients and recognition that this is a hard thing for people to experience, that these events are scary. So we need to have that empathy and compassion for these patients and how we approach them and how we communicate with them on a similar level as we would any other neurological diagnosis. And there's still some gaps there, probably in practice. There is some really good literature out there on differences in semiology between epileptic seizures and non-epileptic seizures. There's been a few really good papers that have looked at clinical distinction. And when you drill down on the semiology, which is what neurologists are really good at, right, is taking very detailed history and thinking very granularly about what's going on with the patient, there are lots of ways that we can pretty easily differentiate epileptic seizures from non-epileptic seizures. And then the second really important piece is communicating the diagnosis to patients and their families, in the case of pediatrics, in a way that facilitates understanding, and the patient and their family or caregivers are able to agree with and understand what's going on with them, and to be able to accept and agree that that's the right diagnosis and move forward with treatment. So I think that's another potential gap that we are seeing in these data, but potentially may also exist out in the real world.
As we've been saying, this is something that should be bread and butter for practicing neurologists, child and adult neurologists alike. It's so common and it can be challenging, but there are some good resources out there, like you said, in the literature that could help us improve based on a semiological approach to making this distinction between epileptic seizures and non-epileptic seizures. Afsaneh, we've talked about these educational gaps. And so transitioning a little bit more to thinking about ways to fill those gaps and to teach these skills that we've been talking about. And you mentioned simulation as one example that the learners you surveyed identified as a way they would prefer to learn it. So what can this study tell us about possible strategies that we can employ to improve the educational methods, the way that we're teaching the clinical approach to psychogenic non-epileptic seizures?
The residents reported not only the desire to learn more about how to communicate the diagnosis, which, we've come to understand during this talk, that is one of the key components to getting the patients and families to accept the diagnosis and then go on to treatment. But the other area that the residents really reported wanting more education and direction on was how to direct their patient to the appropriate treatment. And we know for psychogenic non-epileptic seizures that psychotherapy and cognitive behavioral therapy are the ideal treatments, which is beyond the scope of our practice. But as neurologists, we can provide a lot of psychoeducation ourselves that can help bridge that gap from diagnosis to treatment by the psychologist. And so one area that also needs targeting is the psychoeducation piece of what things we as neurologists can communicate to patients and families in that initial diagnosis communication that we have with them. And so our residents and program directors both agreed. We gave them options of what types of education they want. And again, the simulation-based teaching was by far the most preferred method of learning. And so we need to be better about creating curriculum in that regard so that these residents can practice their communication, get out all the mistakes they make out in that practice so that when they're in front of the patient, they can feel confident in how they talk to their patients and families. Our other hope is that a lot of practicing neurologists who are out of training are also reporting difficulty with this diagnosis, with communicating it and talking about treatment. And so one of our goals is to also bring some of this education to some of our national conferences to further help our colleagues improve in their practice on this diagnosis, since we know it's not just trainees, but neurologists and epileptologists still could use some more education on this seemingly difficult, but really at the end of the day, straightforward diagnosis that just needs a little practice.
And thinking about the way we teach this is depend on the audience and the location that we're teaching it within a residency training program, perhaps developing, like you said, simulation curricula that can be applied to a group of residents, but that may not be as feasible in a CME national conference setting. What are some key clinical lessons that you think are really critical to include in future curricula that are going to help those recipients really better recognize and perhaps more importantly, manage the care of patients with PNES?
The first step is really making the correct diagnosis, recognizing the semiology features, reviewing videos. So curricula should include not only discussion of semiology, but ideally recorded events, reviewing videos of patients having events, and also hearing descriptions of events. What are the typical ways? I mean, there are a lot of common themes, at least in my clinic, that I hear from patients over and over and over again. One of the key questions that I have found to be so helpful in recognizing or differentiating these events from epileptic seizures is this very simple question of, do you have warning symptoms, first of all, which most patients do have warning symptoms before they go into their event. And then, have you ever been able to hold off or stop an event from coming or progressing once you felt your warning symptoms? And many times the patients say yes, and I can have very high confidence that that is a non-epileptic seizure because you would not have any sort of voluntary control over an epileptic seizure, right? So it's these key history-taking questions that are very, very useful to clinicians to be able to recognize, to ask questions about the semiology and recognize distinctive features that suggest epileptic seizures or that suggest non-epileptic seizures. And also watching videos of semiology, again, to drive home that point of what do these events actually look like and what do they feel like? What are the subjective symptoms that people experience? And then once we have been able to accurately make a diagnosis, then the next really important step that is actually really the first step in treatment is that communication of the diagnosis and some psychoeducation, as Afsana was talking about. We don't need to be psychologists or psychiatrists. That's outside the scope of our practice, but we can have some sort of psychologically minded verbiage that we use to communicate with patients about what these events are, what are some of the precipitating and maintaining factors, predisposing factors to help them understand what's going on and get them ready for the next step, which would be cognitive behavior therapy with a psychologist, getting the patients and their families on board to move forward with treatment.
I really love that question you highlight about patients being able to abort or stop their event before it progresses. And I'm looking forward to the clinical paper you're going to publish on the sensitivity and specificity of that question so that we can feature it again on the podcast. I've been speaking with Afsana Talai from UT Southwestern in Texas and Dara Albert from Nationwide Children's Hospital in Ohio about their paper published in Neurology Education titled Educating Child Neurology Residents About Psychogenic Non-Epileptic Seizures on the Green Journal website, following the link to the journal Neurology Education. Dara and Afsana, thank you so much for joining us. This was fantastic.
Thank you so much for inviting us.
Thank you so much for having us.
Hey, this is Jason Crowell. Thanks for listening to the Neurology Podcast. Today, we're discussing a paper that was published in December 2023 in the journal Neurology. The paper is titled Game-Based Learning in Neuroscience, Key Terminology, Literature Survey, and How-To Guide to Create a Serious Game. Joining us, we have Sarah Edwards. Sarah is an emergency medicine resident in the UK associated with the National Health Service. And we have Zach London, who is a neurologist at the University of Michigan. Sarah, Zach, thank you for joining us.
Thank you.
Thanks for having us, Jason.
I'm curious how you guys decided to do some research and publish on games in neuroscience and games in neurology. What was the impetus for this? I'm curious.
We are part of a informal gaming group, I guess, which is how Zach and I met, because obviously I'm in the UK and don't work in the US. And essentially our love for games came together by a colleague, Michael Cosimini, in a Slack group called the Gamer Collaborative. And we met through that, really. So all of the authors met that way, using a mix of my experience of sort of gaming and that sort of thing with the neurology type things that Zach brings. I think that would be about how it worked.
Very good. So before we talk about neuroscience games specifically, it would probably be useful for us to do some definitions. So you spell out some of these things in the paper, but we even have to define game and to gamify a topic or gamification. What do we mean when we're making a game or turning things into a game? How would you describe that?
Well, there are a couple of ways to think about it. And I think the term that you probably hear and that you just used, gamification, is, I think, a term that people probably misuse to some degree. Gamification is really when you take something that is in a non-game setting and you add a game-like element to it, right? So, I think the classic gamification would be like getting badges for doing something or getting reward points or, just a Fitbit counting your steps. Or neurology, I think about the Question of the Day app, which has leaderboards and has streaks and things like that. The thing to realize is that that's not a game. That's just asking you trivia questions, right? But it adds this game-like element to something that otherwise is a different activity, like walking or exercising or buying coffee or studying neurology, write review or CME review questions. So that's what gamification is. Not the same thing as making a game per se. When I think about a game, I think of something that is truly interactive and it can't be sort of separated from the other activity. And that's where we come to this term serious games, which people use to define as games that are really directed primarily at the purpose of education. Ideally, they have actual learning objectives, and they're accomplishing those objectives in a way that's sort of prioritized over fun, I guess. And most importantly, like the educational lesson is really integrated into what we call the core gameplay loop, which is basically what you're doing where you're making choices and getting feedback. And so I think those are sort of opposite ends of the spectrum. Gamification is not a game at all, but adding a game-like element. Serious games are games that are integrated primarily for the purpose of education. And then there's this whole world of games that can educate but aren't really serious games. And I think Sarah and I, we talked about this a lot. We kind of struggled because I think in the literature, people don't really have a word for this. But we've used the term game-based learning to be sort of a superset of all of these things.
Terrific. So, within the world of neurology, we often encounter individuals, and we ourselves experience this neurophobia where it can be dense, difficult to understand material. I've often argued that maybe peripheral neurology should be a separate specialty rather than the regular neurology with your nerves and plexuses, et cetera. But what would you say is the utility of then gamification and game-based learning in the world of neurology and neurosciences?
As the non-neurologist and being an emergency medicine physician, for me, neurology can be quite scary. I mean, common being common, I see strokes, I see bleeds, I see that sort of thing. But actually, true neurology is difficult. I think there are huge numbers of games that we found during this project. Really lucky that Zach has created some of them. And what it does is it breaks down that neurophobia. It makes it a bit less scary, a bit more fun. One of my favourite games to play is called Foramina, and it's cranial nerve themed. It's a tabletop game, and it's so much fun. Like, to know the 12 cranial nerves. I played it for the first time last year, and I'd never come across it. For somebody that has to examine the cranial nerves quite often in my job, it really helped for me to relearn them and reimagine them in a fun way. And I'd be interested to know, like, Zach, what you think, being from, a neurologist and versus me, a non-neurologist.
A lot of things that make games good for education in general, and we could touch on those. But I think if you're specifically asking about neurology and neuroscience, the thing that drives a lot of people away from neurology is sort of the complexity of the anatomy and neuroanatomic localization and sort of understanding tracks and that sort of thing. And I think those things are just perfect for games. I mean, I think when I look at a lot of the games that I like to play are based on maps, right? There's a map of some countryside or of the world, if you play Pandemic or Catan or Carcassonne or some of these other sort of modern games. A lot of them are based on maps, and the whole nervous system is a map, right? I mean, that's one of the things that we like about it is the central nervous system kind of has pathways, the peripheral nervous system has pathways in a map. And so those things are, I think, really ripe for having games made out of them. One of the challenges, of course, is when you're making a game, you want to have material that is sort of timeless. You want people to be able to play the game 5 years from now or even longer and still have the things in it be valid. And of course, in medicine, everything changes all the time. Half of what I learned in medical school isn't true anymore. But that's one of the things that's sort of appealing about anatomy and localization is they haven't changed since Charcot was doing this. And they're hopefully not going to in the next 100 years either.
So in this paper, you do a survey, a literature review of what's been published about neuroscience games, then also provide discussion of the different games that are currently available. What are some of the more common ones that we may have heard of, and how do they work? What do they teach?
I don't know if the ones that are available are really in the common parlance right now, but there are a number of them out there. And I think some of the ones that we touch on that really fall into the category of serious games that are commercially available one way or another. There's a game called Stroke of Genius by Ann Helms, who's one of our co-authors, which is where players have to formulate an evolving story for sort of a stroke syndrome related to cards that they draw that have to do with anatomy and risk factors and pathophysiology. There is a game that's a little bit more basic science oriented called Signal by Angel Carr, which is, I think you have to sort of build a synapse using a deck that has proteins and molecules. And there's a really cool neuroanatomy game by Austin Lim called Neuronavigator, where you're moving around in coronal sections of the brain to try to get to certain neuroanatomic locations faster than other people. Some of the ones that I've been involved with are called The Lesion and The Plexus. Those are both anatomy localization games. The Lesion is about central nervous system. The Plexus is about peripheral nervous system. Sarah mentioned foramina, which is about cranial nerves. So you're kind of getting a sense that a lot of these are anatomy-based. And maybe by the time this podcast is finished, I have another one that I'm hoping to have available real soon, which is called Field Cut. And it literally is just about the anatomy of lesions that cause visual field deficits.
In this paper, you guys also do a literature review about what's been published about games and gaming, including in neuroscience. Can you talk about what you found in that review?
We had a brief look at the literature because I think it's really important to understand what's out there, what's published. So we did a systematic search of the literature, and this took us all the way up to March 2023. And from that, we ended up with 2,068 articles, which whittled it all the way down to 13 unique games. Not all of them were named. Some of these were original research, so going off and doing a paper about how the game changed X or Y, and some of them were conference abstracts. So those are the games that are available. And if you have the opportunity to look at the paper, we list all the games. And then what we did as well, we also had a look at the sort of games that were available sort of commercially. And I think looking at that was around 14 available games that commercially you can buy. And these games were not always the same as the games that were published. So there's quite a lot of games available. Some of the games that were published never came more than the conference abstract. And some of the games that are published that are commercially available have never been researched. So I think there's quite a lot of games out there, quite a lot of unique games out there, but not all are available. So I think it's useful to kind of know that.
And I think that makes an important point, Sarah, because I was in a room full of people at a meeting recently, and I asked how many people in the room had ever made a game for education, and half the hands went up, right? So a lot of people are doing this for their own learners. But as far as making games that are sort of more widely available, this is really still a nascent field. There are not very many that are available to the public or commercially available yet. And I think this is a community we're interested in growing. And I think the evidence behind games for education has certainly grown a lot. And so I think that there's an opportunity for creative educators to really make their mark in this area.
And to that end, one of the things you did that I really appreciated was you go through and give how to think about designing a game, which I really felt was fascinating. I'd never given much thought to almost the science or the steps involved in creating a game. Could you share with our listeners how that works?
I think there are 4 overall phases when you're thinking about designing a game. So there's the phase 1, which is your sort of preparation phase. And I think this can be subdivided into thinking about things about, content or domain and what you want to talk about, thinking about your audience and setting. Well, who is it you're doing it for? Is it for your undergraduate neurologists, or is it for your postgraduate doctors? Who's it for? And then thinking about, equity and representativeness in the sense of, are you going to be able to cover something that's realistic? What do you want to cover? So that's sort of your preparation phase. And I think this can be, and often, I don't know about Zach, but when I'm sitting down creating games, there's literally bits of paper, post-it notes, pens, just getting thoughts down on those sheets of paper. So that's phase 1, so your preparation sort of phase.
And I would just interject and say everything that you've said so far is basically defining what you would want to do to create any educational lesson, any curriculum, right? I mean, so this is sort of coming up with the idea of what you want to teach and who you want to teach. And then we start making a game.
Yeah, absolutely. And often preparing for anything that you do, you might get a bit of paper down, you might get your iPad out, you might be jotting notes down, thinking about, well, what is it I want to do and what am I setting out to achieve? And then phase 2 is your game design. And that's thinking about determining what the nature of the game is, what your game mechanics might be. So that was phase 1, the preparation phase. And then secondly, I often thinking about phase 2, which is your game design. So thinking about the nature of the game, thinking about, well, what are the game mechanics that might work? So could this be rolling a dice and maybe moving along a board? Could this be like matching cards? Could this be more complex? And then the last thing that I always think about with game design is selecting the best medium. So does it need to be a board game? Does it need to be matching games? Could it just be dice? Could it be digital? So those are some of the things to think about in the game design phase.
Yeah, and I think the key here is when she's talking about mechanics, this is just like not just the rules of a game, but sort of the broader ways that you interact with the game, that players interact and strategize and achieve goals. And it's not something you really think about until you start playing games, that games sort of have a finite number of these mechanics, right? I mean, she mentioned rolling dice. Like, not every game has that, but that's something that's very common. And you'll start to recognize that there are 20 or 30 mechanics that show up in games over and over and over again. Managing hands, restricted communication, card drafting, deck building, push your luck. These are terms that won't mean anything to you until you start playing a lot of games. Then you realize they are coming up over and over and over again. So I would say the secret here is just play a lot of games. Like, go to the library and take home games and figure out what you like, figure out what are sort of the mechanics that give you those moments of excitement, and also figure out what you don't like. What are the games that you find frustrating or boring? And then if you want to make a game, start looking at the mechanics that excite you and think about how you could apply an educational lesson to those.
You've hit the nail on the head there. I think it is play lots of games and just test out what is it you like and work with something that you like and work with something that you're familiar. Keep it simple. I always say In emergency medicine, keep it simple. I think with game design, just start simple. You're not going for really complex, all-day playing Dungeons and Dragons style gaming. You want to keep it simple. And then comes phase 3, which is iteration and play testing. So this is about, you've got to start designing something, I guess. And as I said before, you think about create a minimum viable product. So get your Post-it notes out, get your big sheets of paper, get your felt tip pens out, start scrawling, drawing. It doesn't need to be all singing, all dancing. Within it, particularly within topics that you might be picking, make sure that you've got equity, diversity, and inclusivity so that you're not stereotyping particular conditions or peoples or genders or etc. You get the idea. And then the other thing to think about is reviewing and refining, very much like, you would do with a presentation or a teaching thing. Well, how are you going to review it? How are you going to refine it?
And I would suggest also trying it out with different audiences, right? I mean, so start with collaborators, people who have been involved with playing a lot of games, then work with people who don't play games, but are sort of the level of learner that you're going for. Because I feel like a lot of times my instinct is to make games that I want to play. And the games that I want to play often have 50-page rule books. And I realize that the people I want to teach are not interested in games with 50-page rule books.
And again, when you're starting this out, going back to each phase, keep it simple. And then get confident with what you're doing. Play something that's familiar, play something that is safe, and then you can go as complex as you want.
And it's okay to use existing games and put a Neurology stamp on them because, you can't actually patent a game mechanic. So, for instance, people already know how to play Taboo, so you make a Neurology version of Taboo. It's super easy. It's guaranteed to be a hit because you already know that mechanic works. And so if there are games that people already know how to play, like Twister or Jenga or anything, think of some way that you can just turn that into an educational game, and then you won't spend half an hour explaining the rules to everybody.
Yeah, and lastly, it's the 4th phase, which is sort of implementation and evaluation. So thinking about funding and manufacturing, if that is important to you. It doesn't have to be. It's not the be-all and end-all for everyone. Thinking about marketing and publicising the game, because those probably will go together if you're thinking broadly and wanting to make some money or what have you, or even some return for the time that your department has given you to develop this game. And finally, how could you potentially thinking about future-proofing it? What could be the next steps? Is what you're producing now going to be relevant in 5 years' time or in date 5 years' time? And if it isn't, that's fine, but how are you going to update it?
I find that those steps really helpful. I think the thing that stood out to me the most was understanding this idea of game mechanics and realizing that creating a new game doesn't require creating a new mechanic. And in fact, creating a new mechanic might actually work against you because using one that's already known and available and successful is going to help it succeed because people already know how to play it, so to speak. Well, terrific. Thank you guys so much for that review. Again, I'd encourage you to check out the paper. The title of the paper is Game-Based Learning in Neuroscience, Key Terminology, Literature Survey, and How-To Guide to Create a Serious Game. It was published in the journal Neurology in December 2023. And again, I want to thank Zach London from the University of Michigan and Sarah Edwards from the National Health Service for joining us today. Thank you. Appreciate it.
Thanks again, Jason. This was a lot of fun.
Yeah, thanks very much.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. Today on the Neurology Podcast, we're joined by Casey Alvin from Emory University in Atlanta, Georgia, where she is a neurocritical care specialist. But many of you are going to know Casey perhaps even more from her role as an educator, particularly via social media. And today we're going to discuss her paper that was just published in Neurology Education. The title is Making a Tutorial Fly, Features of Educational Social Media Posts Associated with High Sharing and Engagement. Casey, thanks so much for coming on to talk about this.
Stacey, thank you so much for having me. It's really quite a joy to be here.
This is a fun paper, and I don't need to tell you, with the rise of social media, what an incredible tool this is, and you certainly have mastered the ability to use this for education. So before we get into all the cool aspects of what you did in this paper and your research in neurology education, give us the broad strokes. If I want to have high impact as a neurology educator tomorrow on my social media, what are the top 3 things I need to do when I post?
I think there's a lot of ways that we could answer this, but I think that you can probably boil it down to, first and foremost, having a creative hook. If you're teaching about something, be passionate about that and have a way that makes people know why it matters to them. Number 2, be really clear about what you are going to teach people. And number 3, if you can make it visually appealing with some sort of original graphic, at least within the platform formerly known as Twitter, now we call it X, that's going to be really important. So I would say those are my top 3 takeaways from this work and just my anecdotal experience having been on social media for quite some time.
That's helpful. I think I've got it. But that's also a lot of work, right? I think sometimes we think people just take 3 minutes and go make a post and it's viral, but I already hear you saying there's a lot of strategy here. So let's get into some of the details. For this study, you created a data set from the social media platform X. Tell us about the parameters of that data set and what was included in what you looked at to get data here.
Absolutely. So we were specifically interested in looking at what makes tweetorials, which are teaching posts posted on X, formerly Twitter, successful. And by success, we defined widely shared. And so for those who may not be familiar with what a tweetorial is, it is just basically the amalgamation of the words tweet and tutorial. And so it is a series of threaded tweets, which again, remember, are very short posts, 280 characters, that are put together to form a longer narrative with the goal of some sort of educational content. And these got really popular sort of when Twitter sort of allowed this to start happening was in 2018. And we were so curious, why is it that some of these are very widely shared, really liked, reposted, and some not so much. But the problem is that X is pretty ephemeral. These are not indexed. So we did a lot of creative things to try to create a data set of neurology themed tutorials. We looked at hashtags. We looked at authors that we knew regularly posted tutorials. We even leveraged a sort of independently maintained collections of medical themed tutorials that's housed on a website. And so that's really how we got this data set, which ended up being almost 400 neurology themed tutorials.
Wow, 400. That's a fair amount to sift through. I already have some questions based on reading through the paper. So one that struck me as very surprising was your finding that both continuing medical education, or CME for short accreditation, and separately tweets with a positive tone, both of those factors. So offering CME through a tutorial and I guess being overly optimistic or positive, both of those things negatively affected what you call the X factor. Maybe I shouldn't be surprised, but why do you think that is?
What we termed the X factor was a way that we could compare these neurology themed tutorials that were posted through the years. And the X factor is basically looking at how widely shared, how many impressions, how many times were they reposted, what was the sort of engagement in the community. So something with a high X factor had high sharing, had high engagement. And this was a really intriguing finding for us as well, that this CME accreditation and having this positive tone sort of negatively predicted if something was going to be widely shared and retweeted. And actually, let me start with the CME. So this to me was initially quite perplexing because I think we would want to know that CME means that this is probably more valid. This is a more verified source, right? This seems on the face value to be something that we would want trainees to engage in. But if you dig a little bit deeper, these CME tutorials are often posted by institutions or by CME accounts that are pharmaceutical sponsored. And that was, I think, the sort of underlying cause that was a little bit different than other tutorials, that these were not being posted from personal accounts. These were, in some cases, paid experts that were writing CME accredited tutorials, but were being paid by pharmaceutical companies. And to me, that actually is sort of showing that neurology Twitter community is fairly, maybe not suspicious, but is actually trying to check their sources and trying to think about why is someone writing something. And so I think in some ways that we can be actually a little optimistic that we are actually trying to teach trainees and practitioners to understand motivation behind posting and to really question whether or not something is being conveyed with the best intentions. And so I'm not saying that those CME tutorials were influenced by pharma or were not correct, but I think they got lower engagement because there was some skepticism around them. And I think another way to maybe more positively frame that is that people on social media are coming to you because they want a personal connection. They want to see people who are showing up that are time and time again posting reliable, high quality content that they're not getting paid to do. This is coming as a passion project, as something that they feel represents their own sifting through the knowledge and how they've come to the conclusion, or that their residents or fellows trying to say, like, this is something I've learned from. Maybe you will learn too. And so I think another takeaway from that is to show up and have a personal brand on social media. People want to come and learn from experts, but they want to know those experts are people who are doing this for the right reasons. So again, it seems a little bit strange on the surface. I think that this is something that is a good thing about the neurology X community.
Right. So appropriate skepticism. But I guess on the flip side of that, don't be too optimistic and happy-go-lucky when you're doing it.
Fortunately, we did not see that negative tones became more viral. So positive tones, maybe people are a little bit skeptic of. Negative tones did not. Being overly negative is also not a good way to engage. It does not predict high sharing and engagement. But again, I do think maybe healthy skepticism, and probably that's a good thing.
And maybe reflects way back, the individuals who are attracted to this platform tend to enjoy more of a grassroots approach, I think is perhaps a way to summarize some of it or speculate why you found what you found. Would you agree?
Absolutely. I mean, again, I think this really is about forming a community and trying to be fair in our approach of giving data. And so I think being part of that community means having that personal approach.
And let's get back to the visual appeal you mentioned. Visual appeal sounds like it's really important. How are you coming up with these images? And have you dabbled with AI images yet? I guess we won't know for this paper if that makes a difference or not. But what are your thoughts around what type of image is really going to be the one that resonates the most?
I think any image is probably better than none. Text-based things we know are less shared than ones that have an image. But the ones that really get shared are the ones in which the author has put together a specific author-made graphic that represents what they're going to teach in that tutorial. Sometimes that's an infographic that they've put together. Other times it may just be some original thing that they've posted that sort of in a nutshell explains it. But those unique author-made graphics were the single most positively influencing ways that you can manipulate a post that would help get more sharing and more engagement. And then in terms of the AI thing, we don't see that in this paper because this predated the use of AI to generate images. But anecdotally, I do think that those can be helpful in cases where you're trying to teach something that doesn't have, maybe it's not easy to make an infographic about it, or you can't put together their own way to visualize this. I think that that's a really exciting tool that we're going to see more and more in the social media space.
Yeah, it will be interesting to see again, does this community like things that feel real, or are they okay with things being jazzed up a little bit by AI? It would be a great follow-up. I'm not signing you up for more work. I saw in your paper there are a couple of figures with impressions on the axis, and I noticed that there are a few outliers there that got quite a few impressions. Did you look in any detail at those really extreme outliers, and can you guess what made those go viral, or is it a mystery?
No, this was a really interesting part of the paper. And we do know there are neurologists writing neurology-themed tutorials, but there are ex-influencers that usually are from sort of the medicine or emergency medicine space. And again, those are much bigger subspecialties, right? Internal medicine, lots more doctors than neurology. And unsurprisingly, those authors have orders of magnitude higher followers than most of the neurologists. And so unsurprisingly, when they write a neurology-themed tutorial, and some of these were really wonderfully done, they were really great posts, but they just had a way, way, way bigger audience. And so unsurprisingly, those great posts went really far. And so one of the things that we found is that neurologists in general have a capped influence just based on our subspecialty. We in neurology have a smaller neuro Twitter community than something like all of med Twitter or emergency medicine Twitter or critical care even. And so I think it does sort of matter how big your audience is, but within the same order of magnitude. You know, most of our sample was kind of within 200 to 1,000 followers. Then it doesn't really matter how many followers you have. when you're posting, the thing that's going to matter most is really, did you create a post that has that visual appeal? Does it clearly articulate what it's going to teach? That those features that we talked about at the beginning of the hour really make more of a difference than just the number of followers. And the way that we sort of corrected for the number of followers was some fancy statistical massaging that looked at the way to generalize that, which is called the generalized estimating equation. So we really did take that into account when we were looking at what are the things that we can do and how does that influence within a similar magnitude of following.
What I'm taking away is if you want to win the popularity contest, you probably shouldn't be a neurologist. But I think we all knew that. No, we're just kidding. But you're able to see within the intended audience, right? It is a smaller audience, a smaller social media family. Again, it gets back to your point about what is your message. And if your message is for neurologists, then keep it for neurologists, and you really can't focus on magnitudes of sharing.
Absolutely. I think that really is the takeaway. I mean, we want to write neurology themed tutorials that are going to be resonant to our community. And so again, that might not win the popularity contest of all of X, but I think that we are still getting the message out to the people who will really care and take that message to heart.
And when you talk about the neurology community, there are layers there as well. And what social media has done is really allow us to be more connected internationally. I've certainly noticed that just over the past few years. And the intriguing part to me about social media, and frankly, the podcast, as well, is that we can hit some unique audiences, some otherwise not interconnected with each other demographics. Did you have any measures or ways to tell, were your tutorials hitting an audience that you wouldn't normally be able to interact with?
Yeah, this is, I think, one of the most exciting parts about the social media-based community. We know that these tutorials get read in 130 countries. We see a huge amount of retweets, reposts, engagement from Brazil, from India, from all over the globe. And to me, that is really the power that we are being able to reach a global audience in the same way this podcast does. I mean, this is the value of some of these sort of non-traditional ways of teaching, is that you get to engage and reach such a huge number of people. I think that's really exciting.
I couldn't agree more. Of course, it doesn't work if those tutorials are not high quality, right? So how much prep time goes into your tutorials?
So I've been doing this for a while. So I think a lot of it has become more efficient as I've had more experience doing it. And even then, it really depends on how comfortable and familiar I am with the topic that I'm talking about, which I think all educators probably resonate with, right? When you're teaching something that you know and deal with day in and day out, it's very easy to distill that to learners. When you are using teaching as a way to kind of help yourself understand something more deeply, then it takes way more time. And so I think it's a little bit of a combination of both. Certainly most of the things that I write tutorials on are things that I'm pretty comfortable with and spend a lot of time dealing with. However, there are some times where I really want to get better at understanding something, or I've never thought about something in a way that came up on rounds. And then it's going to take me a lot longer to kind of shift through the data and understand, what do we know? What do we not know? And then how can I present that in a way that a lot of people can resonate with and can understand? And I think all the educators who are doing this are probably in a similar situation, that some of the things that they tweet about don't take that much time, and some of them take a lot more time. I think it really runs the gamut.
So what's the longest you've ever spent on a tutorial in an area you were less familiar with?
One of the ones I wrote, now this has been like a long time ago, was about antidiuretic hormone. And I probably spent a week like looking at all the different ways that we use antidiuretic hormone in the neuro ICU as both DDAVP, its analog, and as vasopressin, which is the same medication, but just on a different name, hitting different receptors. Got really into the weeds with the receptors. Like this was like a very, very deep dive into pharmaceutical land and receptors and basic physiology. And it really took a very long time for me to tease that out and then presented it in a way that I felt like people in the critical care and neurocritical care community would appreciate. So that was probably the longest I've ever gone on a very deep dive. And it was like a week-long experience in understanding a lot of physiology.
You know, it brings up a question. This is a lot of work to be done well. So do you happen to have a sense of if academic institutions, at least in the US, are giving credit more and more for this sort of effort? And really, arguably, if done well, good PR for the institution, even though it's not peer reviewed? What's your sense of where the state of things are at here?
I think this is really reflective of the discussion that's happening at institutions across the nation, because this is a good way for people to teach. This is a great way to reach a lot of people, but it is not through the traditional scholarship of a peer-reviewed type situation. I mean, quite often these are transparently not peer-reviewed, and they are pretty honest about, this is my opinion. Take it with a grain of salt. I will say that there certainly have been studies. There was a really nice one published in Academic Medicine looking at PNT, sort of promotion and tenure. What do you have to do across many, many academic centers? And many mentioned that you could list whether or not you've written tutorials or participated in podcasts or written blogs, and that was something that you should include on your CV. How those get compared to your more formal PubMed indexed peer-reviewed papers, I do not think that they are held in the same regard. And that's probably fair. Like, they probably shouldn't be held in the same regard. However, what I do notice is that being part of this community and being part of the social media space does allow such an incredible degree of networking, that this is not only a good way for people to get their institution's name out there, but also it is personal brand development of, hey, this is what I really care about. This is what I'm passionate about teaching about. And so I've gotten to know and network with so many different people. That's led to academic collaborations, to speaking opportunities at conferences, to getting to write editorials, things that have real bearing on my CV from a traditional PNT perspective. And so one of the things I always tell trainees when they're asking me, like, is it worth it? Say, absolutely. If you're going to go there to be really deliberate about the message that you're creating, and people get to know you for that message, then this opens a lot of doors. And maybe it's not just because it's a line in your CV saying that you've written a tutorial, but the people you get to meet through that community. And you find these other people who are so passionate about the same things that you are, and get to reach people that maybe didn't know a lot about your specialty, which I think is also pretty unique and amazing. So that's kind of a circular answer, I think, to your question that says, yeah, a little bit, but I think that there's probably value beyond just the line that you might put on your CV.
That's good to hear. You know, we talk about this obviously as well in the audio space. And I think the underpinning of a lot of promotion and tenure is contribution to the science, but there's always these questions or these boxes to check about international recognition of your work. And it is hard to argue with either the audio, Neurology Minute or Neurology Podcast or social media in terms of the international dissemination, right? It's 100-fold probably what you could achieve elsewhere. So I think it would be interesting for me to see, I haven't seen it yet when I've written letters, if people have the impressions of their social media posts on there. I haven't seen anyone gone to that extent yet. I do hope that people get credit for this because I certainly find it valuable. I don't always have time to sit down and read through an entire manuscript. But while I'm picking someone up or running errands, I have 10 minutes to go through a well-written tutorial. So I do hope we get better at somehow assigning value to that. Related, do you still think that X is the best place to focus your efforts of all the choices available for social media? Have we passed the peak of X?
So with the neurology education research that we did, Zach London wrote a wonderful editorial looking at just this question. Has the X-based learning really passed, or are we kind of at a steady point, or do we really just need to go somewhere else entirely? I sort of answer yes and no on this as well. The platform has changed, and that may even change further. And I do think that we need to be mindful that, especially among Gen Zers, they are more comfortable with this sort of short format video content. I think that as educators, we always want to meet people where they are. People love podcasts because they are easy and convenient. They can listen to them on the go. That's why this has taken off as a podcast. Similarly, I think our younger learners like that they can scroll on Instagram, and sure, they're maybe getting content that's not related at all to neurology, but to get a short format video probably would appeal to a lot of our younger learners. And so I do think that it is important that we start to learn how to leverage that content to deliver high quality teaching and engagement with academic neurology. This does not matter what platform you're using, or if you're doing blogs or podcasts or Twitter or TikTok. I think it's crucial to be mission focused, to have a concrete and clear, why am I here? What do I care about? What do I want to show up? And like, what is keeping me at night that I want everyone to know about? And for me, that's always been acute neurologic emergencies and delivering high quality care for these patients as they move from EMS to the emergency department through their neurocritical care stay and even beyond that. But showing up with I really want to share X. I've had the opportunity now to do a lot of digital-based teaching, and that is always what I tell people. This should be your guiding principle. Have something that you are excited to share, and definitely don't go on just to like doomsday scroll. Like that will be a huge waste of time. Be focused, be clear, and be consistent about that message.
Well, I can't argue with that. I really appreciate you sharing your expertise. Casey, this is really great information on a rapidly moving target in the world of social media education. Thank you for sharing your work and for all your tutorials as well, which I know many of us enjoy. Again, Casey's paper on this topic specifically is available in Neurology Education. The title, Making a Tutorial Fly, features of educational social media posts associated with high sharing and engagement. Thanks so much, Casey.
Thank you so much, Stacey. It was really quite an honor to be here.
Hi, it's Jeff Ratliff with Thomas Jefferson University and the Neurology Podcast. I'm here with Rachel Gottlieb-Smith from the University of Michigan and Catherine Zixes from the University of Virginia. Rachel and Catherine are two authors from a recent Viewpoints article that was published in Neurology Education back in September of this year, titled Artificial Intelligence in Residency Recruitment, Impact on Equity. Listeners to the podcast don't need to look far to find examples where we've gotten into topics surrounding the explosion of artificial intelligence technology and how it's really coming to change our lives across different areas of neurology. Even back in January of 2023, just a few months after the release of ChatGPT, Stacey Clardy spoke with Stephen Marsh from The Atlantic about what the future of neurology and science and writing may be looking like following the release of natural language processing technology. In subsequent episodes, we've talked about artificial intelligence use in the interpretation of EEG. And this past summer, Andy Sutherland interviewed Lydia Mora about the use of large language models to improve efficiency and quality in neurology care. So in that vein, we invited Rachel and Catherine to the podcast, and we're going to turn the lens now towards neurology education and residency recruitment and talking about training and recruiting learners in neurology. And in this paper, Rachel, Catherine, and their co-authors really guide us to consider both benefits as well as some of the pitfalls and dangers of implementing AI and machine learning into the process of recruiting for neurology residency. So without further ado, Catherine, Rachel, welcome to the podcast.
Thanks for having us.
So Catherine, I want to start this first question for you. And this paper really points us towards kind of a double-edged sword of using artificial intelligence, especially when it comes to evaluating residency applications. And perhaps before we jump into the implementation of AI, for our listeners who aren't part of the residency program recruitment process, can you tell us about the recent landscape of residency application review and how it may prompt program directors to be looking towards AI to help them?
Absolutely. So what we've seen over the past several years is actually an increasing number of applicants to neurology, both child and adult neurology. And that really has continued to expand since we adopted the virtual recruitment format several years ago. Let's talk a little bit about the data over the last 5 years. Most recently, it was released by the AAMC for this current recruitment season. And what we're seeing in terms of trends, in adult neurology, there are 135 more applicants this year than in the past. But looking back to 2019-2020, which was our last season where we did in-person recruitment, that's actually 572 more applicants to adult neurology. So you can see the increase in kind of the trends over time. This year, adult neurology programs are receiving 660 average applications per program, which is, again, a significant increase over the past 5 years. When we look at the child neurology data, we see very similar trends and patterns. This year, we are having 48 more applicants to child neurology than in the past. And for those who don't think about the child neurology numbers as much, that actually is a significant increase because this year we have 389 total applicants to child neurology residency. So 48 is a significant percentage of those. And as with adult neurology, we see the same trends. So 81 more than in the 2019-2020, so our last in-person interview season, with upward trends over that time as well. And this year, child neurology programs are receiving 120 average applications per program, also an increase since our 2019-2020 in-person season. So with these trends and this backdrop, there's also an increasing desire for more holistic review. And this is where we find ourselves with decreasing reliance on test scores, not only because we want to more holistically evaluate applicants, but also because of that recent transition of step 1 to pass-fail. It's just a lot harder for us to really use that as a particular screening or evaluation item. We've also seen decreasing ability for us to use scores and grades from medical school because we know clerkships and pre-clerkships have really moved and pushed or are in the process of moving toward more pass-fail type evaluations. Same thing is true for class rank. And so when we look at that all together, we really need a way to holistically evaluate people. And so the question becomes then, how do we evaluate an increasing volume of applications still in a holistic manner? And really, can we harness AI to do that? Can AI help us make that more equitable and a more complete process?
Rachel, given some of that backdrop and the impetus to try to leverage AI technology to deal with these problems, when we're looking at things like natural language processing or machine learning or other subtypes of artificial intelligence, how are they different? What are the pros and cons that these different subtypes of AI are bringing to this context of residency application review?
In general, for application review, I think of predictive AI mostly, and that's the type of AI that can analyze patterns, it can predict future outcomes, and that's in contrast to generative AI, which is the type of AI that creates new content. And then within predictive AI, there are many subtypes, and they seem to be very overlapping. The two that I think of mostly with application review are machine learning and then natural language processing. So for machine learning specifically, that's the branch that looks to see patterns in large data sets, at times allowing machines to then self-learn and adapt over time. And there are different algorithms that machine learning can use. For example, there are regression algorithms that can predict outcomes. There are classification algorithms, and those can see patterns and group data. And that can be used in combination with natural language processing, which is the type of AI that seeks to understand and also process human language specifically. So for application review AI, we can integrate both, and that can allow machines to process and analyze unstructured text and in applications that can be personal statements or letters of recommendation, for example.
Okay, so we know there's a lot of data. A lot of it is language and narrative data that we're trying to go through both per application, multiply that over an increased number of applications. And then Rachel, you outlined how these predictive AI models and some of the machine learning processes or large language models can help us sort through some of that. So what can AI do for us to help human residency program directors sort of sort through a very quickly growing and complex process?
There's this increasing need for holistic review, this increasing number of applications. But we know that time is limited for initial review. Everyone in residency education is very busy, and there's really a fairly short window, right, between the beginning of when you receive applications and need to review them and then send out those invitations for interview. That's really not a very long time. For that reason, human review has often utilized simplistic cutoffs for this initial review. People in residency education, I think we want to do a more holistic job on reviews, but it just isn't always possible depending on how many applications your program has received and the turnaround time in which you need to look through those. So this is where AI comes in. When we train an AI model to assess for the characteristics that our residency program really desires, AI can help us more quickly complete those holistic evaluations. And it's interesting because you might think, well, if I let a machine pick my applicants, I'm going to miss people that I would have wanted. But it's actually been looked at, and we see increased efficiency in the review process actually leads to inclusion of applicants that might have been excluded by a human screening process. In our paper, we discussed an example of this where machine learning-based decision support tool was used for application review in the 2020-2021 application cycle. And that was published by Burke, Raphael, and team. And it's interesting because the additional applicants were actually selected for interview by that decision support tool who were actually excluded by the initial human review that was done prior to them utilizing the AI tool. And this is really often because of a large number of applications or over-reliance on a single application factor. And this is where AI can be really helpful.
And so I am a residency program director. What is stopping me from just full steam ahead signing up for this? And I alluded to at the beginning, this is a double-edged sword.
What we focus on the paper is concern for the inadvertent addition of bias. Even though we're hoping to improve equity, we may actually be adding bias with AI. So for example, if our algorithms are biased, we'll end up with biased output, garbage in, garbage out. So it's really important that we carefully develop and then reassess our algorithms over time and make sure that they're up to date and fair and reflective of our program's vision and mission. There's also potential for historical bias if AI is trained on a historical data set. For example, a set of past applications or CVs from prior successful residents. And in the viewpoint, we talk about a cautionary tale from Amazon. Amazon developed this AI-based resume review program in the mid-2010s that was trained on a historical data set of resumes that had been submitted to Amazon over the prior 10 years, most of which came from men, since there was greater male representation in the industry at that time. And so the system actually learned to prefer men as candidates and developed an anti-woman bias. Of course, Amazon has since scrapped that system. They never put it into use, but we have to be cautious. Even though AI has developed a lot since the mid-2010s, right? We're in the mid-2020s. We have to be cautious about historical bias. And it's particularly concerning in a field like neurology, where significant historical biases exist.
Okay, Rachel. So the process has benefits, but as with many applications, it sounds like we absolutely need to be mindful of the criteria we're putting in and reevaluate the outputs that we're getting. And there are some examples, like you said, for those who are still very excited about this and hoping to leverage AI technology to streamline this residency recruitment process. What specific advice would you give to neurology programs or program directors that are considering implementing and adopting these tools? What are the most important factors to consider here?
I think we need just to be aware of the biases that AI potentially can bring. And it's really important that we look at our rubrics and we make sure, as we were saying, that they're up to date, that they're equitable, that they reflect what we want them to reflect, that we think about these with our program and make sure they reflect the program's mission. And we have to use AI experts in helping us design these models. And not just in the design, but also in the continuous model evaluation and training. So this isn't something that we can just set it and forget it. And we should be using human checks for a subset of applications going forward to make sure that we're not inadvertently introducing extra bias that we weren't aware of, and to make sure the process is equitable. And then additionally, AI may also make more explicit some otherwise hidden biases. So in the viewpoint, we talk about gender biases that exist in letters of recommendation. And we know this, and AI can help point that out so that human reviewers can then take that into account when they review applications. Of course, like we talked about, we have to be careful about other biases like the historical bias in neurology, and we don't want AI models to propagate those historical biases. But there's a lot of potential to improve diversity as well.
It sounds like if people are listening and really want to take home a point, we can't be passive in this implementation process and to be very deliberate and thoughtful about how we're going to use this tool. I think we all know that artificial intelligence is coming, whether we like it or not, and how we're going to use it may be sort of what varies between us. And so it's still relatively new, though, and things are happening very fast. And so what are the gaps in our knowledge that potentially research or education research could help fill going forward? What is it that we can still study and learn about the role of AI in resident selection or resident recruitment?
There's absolutely a lot of stuff for us to still study and learn and think about. as we start to actually implement these models, we've talked a lot here about things we're concerned about or things we think will be helpful, but it's important for us to better understand and actually study what happens when we put these models into play in terms of equity, in terms of mitigating or increasing potential bias. It's also really important for us as a neurology community to think about establishing and developing specific tools that can be used for neurology recruitment, to study those systematically, and hopefully that can be something that helps our entire education community as we think about residency recruitment. As Rachel talked about, it is incredibly important for us to continuously look and evaluate our models and reassess how they're doing. The importance of human checks cannot be overstated on the AI models as we move forward, as things change over time, and we want to make sure that our AI model is reflective of what we think it is and what we hope it is. We are very excited about these tools, and we think they have a lot of potential in residency recruitment.
The lessons learned here really do have an application in lots of different areas, both in education, as we mentioned, in the clinic and in research and everything that we do. I've been speaking with Catherine Zixies and Rachel Gottlieb-Smith about their paper in neurology education titled Artificial Intelligence and Residency Recruitment Impact on Equity. Catherine and Rachel, thanks for joining us.
It was a pleasure.
If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about. The views and opinions of the participants in this podcast do not necessarily reflect those of the journal Neurology or the AAN. Disclosures of the participants are included in the show descriptions, reached by a link on the neurology.org website.